The next speaker is Dr. Sridharan Thivakaran, MBBS, MD, Diploma in Geriatric Medicine. Dr. Sridharan Thivakaran is a senior registrar in nephrology at National Hospital of Sri Lanka. Dr. Thivakaran obtained his MBBS from USTC Chittagong in 2015 and MD in medicine from the Postgraduate Institute of Medicine. He has also completed a diploma in geriatric medicine from PGIM University of Colombo in 2020. The topic that he has chosen for today is renal diseases in pregnancy, challenges in the frontier diagnosis and management. Over to you, Sridhara.
Thank you so much, sir, for your kind introduction. Thank you so much for Ceylon College of Physicians to give an opportunity to present at this prestigious Young Physician Forum. Today, I am going to speak about renal disease in pregnancy, challenges in frontier diagnosis and management. This is the outline of my presentation. There are unique and unremarkable changes that enable the kidney to adjust to the increased metabolic demands of pregnancy. These changes are either structural or functional or hemodynamic changes. And these changes started soon after conception, but that gradually increases and get maximum when the ureter presented blood flow at maximum, but is maintained until late gestation. The kidney volume increases up to 30% due to increase in the renal blood flow and interstitial volume. Dilatation of the ureter and the renal pelvis, known as physiological hyperureter and the hydronephrosis, due to the hormonal effect, external compression, and intrinsic changes in the ureter wall. And the bladder volume increases initially due to the effect of progesterone. Subsequently, the enlarged uterus displaces the bladder and the volume decreases. Hemodynamic changes. Cardiac output. Cardiac output increases throughout the pregnancy due to the increased preload, afterload, and increased heart rate. Regarding blood pressure, beginning of the first trimester, both systolic and the diastolic blood pressure decreases, but falling diastolic blood pressure is greater than the falling systolic blood pressure throughout the pregnancy. As the pregnancy progresses, blood pressure return to baseline. Sometimes we can overshoot the pre-pregnancy level in late trimester. So this differences the cardiac output changes. The cardiac output gradually increases. You get a maximum at the second trimester. Then it gradually comes down. Then postpartum, it comes to the pre-pregnancy level. The peripheral vascular resistance, it also comes down. And it will start to rise, and postpartum, it comes back to the baseline level. So what are the causes of decreased vascular resistance? Reduced vascular responsiveness to vasopressors such as angiotensin II, norepinephrine, increased nitric oxide synthesis due to the ovarian hormone relaxin, altered vascular expression of angiotensin II receptor, and increased renal plasma flow. All these factors are contributing to this reduced vascular resistance. Proteinuria. Generally, urinary protein excretion rises in normal pregnancy. Compared to the non-pregnant level of 100 milligram per day, up to it can increase 200 milligram per day in the third trimester. So urinary protein excretion greater than 300 milligram per day is considered to be abnormal and should prompt further evaluation. However, uncomplicated twin pregnancy can lead to urine protein excretion even greater than 300 milligram per day. Sometimes it can cause diagnostic confusion when evaluating a patient for a preeclampsia. So what are the contributing factors for the physiological proteinuria? Increase in GFR, increase in glomerular basement membrane pore size, increased protein transport across glomerular filtration barrier, and reduced tubular reabsorption of filtered protein. Vascular endothelial growth factor, which is usually responsible for the maintenance of podocyte and glomerular basement membrane integrity. Due to in the pregnancy, the circulating anti-angiogenic factors, which cause this glomerular endothelial dysfunction and proteinuria. Glycosuria is more frequently recognized in pregnancy due to the decreased proximal tubular reabsorption and upended glomerular filtration of glucose. Hyponatremia. The plasma osmolality in normal pregnancy falls to a new set point of 270 milliosmol per kg compared to the pre-pregnancy level of 271 to 290, with a proportionate decrease in sodium concentration 4 to 5 milliequivalent below the non-pregnancy level. This is known as reset osmostat. Is mainly mediated by hormonal factors, mainly increased production of human chorionic gonadotrophin, and human chorionic gonadotrophin acts indirectly via the release of relaxin. So, any sodium concentration below 130 milliequivalent per liter in pregnancy should prompt further evaluation for the pathological cause of hyponatremia. Here, the level is below 130. Increased GFR is observed within 1 month of conception, but it peaks approximately 40 to 50% above the baseline level in second trimester, and physiological increase in GFR causes decrease in serum creatine concentration in early pregnancy. So, serum creatine concentration of 0.75 milligram per deciliter or 70.7 micromole per liter usually reflects the renal impairment in pregnancy. So, this is the graph showing the variation of serum creatine throughout the pregnancy. It will come down in the second trimester, and the next shows at about 20 to 24 weeks, the 95% value is came as around 58. So the value, if you are assessing a patient at about 20 to 24 weeks, because that period is more common for a preeclampsia, the creatine values anything more than 58 or 59, that considered to be abnormal. Regarding the total protein and the albumin, the total protein and the albumin is coming down compared to the antenatal period, first trimester. The second and the third trimester reference range are little bit lower than antenatal period. The albumin level normally is considered to be 2.6 to 4.5, and third trimester it was 2.3 to 4.2 gram per deciliter. This diagram represents the physiological changes as I told before. So I come to a case history. This is 25 years old female, POA of 22 weeks, presented with generalized body swelling, frothy urine for 1 week. This is her first pregnancy. No any prior history of miscarriage or intrauterine death. No significant past medical history. Other than joint pain and generalized fatigue, no any other significant symptom. On examination, blood pressure was found to be 160 by 90. It was normal in her first antenatal visit. By a bilateral pitting angle edema, pale, there was no any evidence of wounds or any cellulitis. So these are the investigations which were done. The first column revealed the first antenatal visit. Most of the investigations are normal during her first antenatal visits. But when she comes to at POA of 22 weeks, found to have like bit of low albumin, but this albumin is compatible with the range for the second trimester, and the creatinine is the usual value. But while observing her urine food report, first antenatal visit, her albumin is nil, but at POA of 22 weeks, albumin was found to have 3 plus, and the UPCR was 1.9. Subsequently, while we observe her at POA of 26 weeks, again the albumin is 3 plus, and there is a significant rest cells of 20 to 30, and UPCR become nephrotic range proteinuria. ESR also slightly raised. Ultrasound revealed right side mild hydronephrosis. Our findings look abnormal, or are they really abnormal? The UPCR of 4.31, yes, definitely has nephrotic range proteinuria, that is abnormal. The right side mild hydronephrosis is a normal physiological finding, and the albumin of initial albumin of 1.88 is normal for the pre-range, but it subsequently reduced up to 2.15. But the creatinine, even though it looks like normal, like 79, but it is more than the 58, that indicates she had a renal impairment. So the patient developed a new onset hypertension plus proteinuria after 20 weeks. First differential I consider as a preeclampsia, or it could be a first presentation of lupus nephritis, or it could be a post-infectious glomerulonephritis, or any other primary glomerulonephritis worsening during pregnancy. So differentiating preeclampsia from lupus nephritis or lupus flare can be challenging, because lupus nephritis flare during pregnancy even can mimic preeclampsia, because rising proteinuria, hypertension, thrombocytopenia, deterioration in renal functions are common to both. Sometimes active lupus nephritis and preeclampsia can also occur at the same time, but If there is evidence of lupus activity in other organ, sometimes help to distinguish in the SLE from preeclampsia. The new onset rash, unusual fatigue, arthralgia, puritic pain even can be associated with normal pregnancy finding as well because due to the effect of hormone, or it could be due to the lupus flare as well. Mild anemia, mild thrombocytopenia, elevated ESR, proteinuria can be observed during normal pregnancy as well. Generally, the complement levels usually decrease during active SLE, but as an acute phase response of pregnancy, the complement levels are rise about 10 to 50%. But we have to, rather than looking at a single value, we have to look at the decreasing trend of the complement level will give more informative value than look at a single value of complements. Albumin level, as I told before, normal albumin for pregnancy is significantly lower. So interpretation of hypoalbuminemia is challenging when patient present with marked proteinuria. Even though serum creatinine looks like normal, but we have to look at the range and we look at the EGFR. ANA is very non-specific, but finding of anti-dsDNA or anti-smooth muscle antibody would confirm the diagnosis. These are some of the differentiating points of lupus nephritis from preeclampsia: the positive active urine sediment, low or decreasing trend of the complement, presence of dsDNA antibody favors lupus nephritis, the rising of uric acid level more than 4.9 milligram per deciliter favors of preeclampsia. Preeclampsia usually occurs after 20 weeks, but lupus nephritis can occur anytime during pregnancy. But how we can differentiate both. There is a thing called the ratio of soluble FMS like tyrosine kinase and the placental growth factor, which usually increase in preeclampsia, but normally in lupus nephritis. I will come with later slides. So back to my case. Further investigations are ASOT normal, ANE, C3, C4, urine for dysmorphic RBC, blood sugar level came as normal. Since the patient present with nephrotic range proteinuria, renal impairment, and black urine sediment, since her POA of 26 weeks, she underwent a renal biopsy. This is her biopsy finding. The 31 glomuli are slightly enlarged. The capillary lumen are narrowed. I will come to this later. And there is no evidence of crescent formation or any leukocyte infiltration. Changes are compatible with preeclampsia. This is known as glomerular endotheliosis, where the capillary lumens are occluded. This is the only capillary lumen which is open. This is a characteristic finding of the renal lesion in preeclampsia, even if it's a pathognomic. It found only in 84% of nullipara with a clinical diagnosis of preeclampsia and only 38% of multipara. It usually disappears 8 weeks of delivery. That also coincides with the resolution of hypertension and proteinuria. Preeclampsia is a multisystem progressive disorder characterized by new onset hypertension and proteinuria, or new onset hypertension plus significant end-organ dysfunction with or without proteinuria, typically presenting after 20 weeks of gestation or postpartum. If 4.6 pregnancies were worldwide complicated by preeclampsia. Usually, the underlying renal disease is an independent risk factor. The other risk factors are past history of preeclampsia, pre-existing hypertension, diabetes, multifetal gestation, autoimmune diseases, advanced maternal age. Those are the other risk factors for preeclampsia. Pathogenesis. The abnormal development of the placental vasculature, that means the development of the normal spiral artery remodeling, is the initial pathogenesis. So that causes underperfusion of the placenta. This underperfusion and the ischemia and the oxidative stress leading to these anti-angiogenic factors. So as I told before, these anti-angiogenic factors are increased serum concentration of soluble FMS like tyrosine kinase and reduced concentration of free vascular endothelial growth factor and the free placental growth factor, contributing to this renal lesion. Routinely, we perform whoever suspected preeclampsia, complete blood count with platelet, creatinine level, AST, ALT, and the quantification of urine reporting by using a 24-hour urine protein or UPCR. This is the soluble FMS like tyrosine kinase. If you have a suspected of preeclampsia, they are having a very high value of this soluble FMS like tyrosine kinase. This will help to cut the adverse maternal outcome, such as a woman with IUGR also found to have this higher value of this soluble FMS like tyrosine kinase. And there is an article which was published in New England Journal of Medicine 2016 that revealed the ratio of soluble FMS like tyrosine kinase 1 to placental growth factor ratio is less than 38, even if you have a clinical suspicion of preeclampsia at that point is quite unlikely. So distinguishing preeclampsia from other hypertensive proteinuria disorder, predicting the short-term risk of preeclampsia with severe feature, and those who ever need urgent management. Suppose if it's a preeclampsia, she needs urgent delivery. So we can determine from these angiogenic markers. Management, the definitive treatment is delivery, and we have to apply the antihypertensive therapy if required. If the systolic blood pressure more than 160, if the diastolic blood pressure more than 110, assessment of fetal growth, we have to perform serious sonography to assess the fetal weight and assess the amniotic fluid volume. Low dose aspirin for the high risk patient to reduce the inflammation and platelet aggregation. Lupus nephritis. SLEs predominantly affect the childbearing age. So it is common to encounter whoever already pregnant or going to be pregnant. So it carries higher maternal and fetal risk. So disease flare during pregnancy carries challenges because differentiating the natural physiological changes in pregnancy can mimic the disease-related manifestation. Generally, the management include the stratification of patients into 3 groups: stable lupus nephritis in remission, active lupus nephritis with severe organ involvement. So stable lupus nephritis, this is the safest low risk period. We have to monitor the patient with the UPCR of every 2 to 4 weeks and discontinue the teratogenic medications such as MMF and convert them to less teratogenic medications such as azathioprine or calcineurin inhibitor. The washout period is generally 3 months. If the patient is stable, if the disease remains clinically inactive over that 3-month period, then she can proceed with pregnancy. HCQ should be advised to continue because it's shown to reduce the disease activity. Sometimes withdrawal can lead to increased lupus flare. Initiation of low dose aspirin and calcium supplement as a prophylactic therapy. Fetal surveillance from the 3rd trimester every weekly interval from 34 weeks. And if antihypertensive therapy is required, you have to start the pregnancy safe medications such as labetalol, nifedipine, or methyl-dopa. Then lupus nephritis with severe organ involvement, they should be counseled regarding the risk of disease progression because they can end up in end organ failure or pregnancy-related risk to the mother and baby. They should be encouraged to consider alternative options such as surrogacy and adoption. Management of lupus nephritis flare during pregnancy, the treatment should not be delayed, but it depends on several factors: severity and the extent of organ involvement, duration of pregnancy, and the benefit-risk ratio of continuing the pregnancy. If the severe flare at early stages of pregnancy, the option of therapeutic abortion also should be discussed because we have to bring down the disease activity under control by administration of early immunosuppressive agent. If it occurs flare at the advanced stage of pregnancy, then we have to treat them with the methylprednisolone and continue with the oral prednisolone with other immunosuppressive medication. Next, I'm going to talk about diabetic nephropathy. It is associated with high risk of pregnancy complication, including the perinatal mortality and the risk of decline in maternal kidney function. Sometimes it can lead to end-stage kidney disease as well. So what are the outcomes of pregnancy? There can be a preterm delivery due to high maternal blood pressure and fetal internal growth restriction, severe congenital malformation compared to diabetic with normal renal function, increased prevalence of preeclampsia due to endothelial dysfunction. Management, generally we have to counsel them the outcome of pregnancy. If the creatinine is more than 170 millimole per liter, is a predictor of pregnancy-induced decline in maternal kidney function leading to end-stage kidney disease. Glycemic control, we have to keep the HbA1c as close to normal, at least 7% is recommended. We have to focus on diabetic retinopathy screening because there are chances to progress to severe diabetic retinopathy, sometimes even slight threatening as well. We have the initiation of antihypertensive treatment. We have if the office blood pressure is more than 140/90 or albumin excretion more than 2 grams in 24 hours. CKD and pregnancy. So what are the challenges? Even the diagnosis of pregnancy is also challengeable because serum beta-HCG is renally excreted. Serum levels may be increased even in the absence of pregnancy in a patient with advanced CKD. So both beta-HCG and ultrasound are necessary. And assessment of volume homeostasis. because typical clinical signs we use a little value such as edema. So we can use alternative approach such as hematocrit or albumin. So rise in ideal value suggest volume contraction. And we have challenge in appropriate use of medication because the typical medication AC inhibitor or SGLT inhibitor we can't use. And management of anemia. Iron deficiency anemia is common in pregnancy as well as common in CKD. So they should be treated proactively. And women with CKD have insufficient capacity to increase the erythropoietin. So dose has to be increased to achieve the same hemoglobin concentration, but cautious about blood pressure control. And vitamin D deficiency is common in pregnant women as well as in CKD because pregnancy favors demineralization. So we have to treat them with alpha calcitriol or calcitriol instead of cholecalciferol when EGFR become less than 30. Pregnancy and dialysis usually improve outcome with more intensive hemodialysis. The benefits are improve urea clearance. So improve urea clearance causes reduce the fetal solute level and reducing the fetal osmotic diuresis, low risk of polyhydramnios, improve blood pressure control, and decrease fluctuation in volume status and less fetal distress. So what is the ideal level of urea we have to keep? We have to keep less than 50 milligram per deciliter or below 17.9. But current recent guidelines say even to keep less than 30, that is also good. For to achieve that, we have to have a 36 hours of hemodialysis. That means at least weekly 5 to 7 sessions per week. Those with end-stage kidneys without residual kidney function. But women with have some residual kidney function may not require as many hours of hemodialysis. Heparin anticoagulation is safe. Pregnancy and renal transplant. Fertility rapidly improve with few months of transplant. So appropriate contraceptive advice given before transplant to avoid pregnancy in early post-transplant period because that's the period we are giving the maximum immunosuppression. Generally, the immunological changes protect against acute rejection. The gender pregnancy outcome are live births at around 75 to 80%, miscarriages 15%, and stillbirth 5%. This is the European Best Practice Guideline 2001 recommended to become a pregnant. These are they should fulfill following criteria. They should be in good gender health for about 2 years, good stable allograft function, generally creatinine level less than 125, no rejection within 6 months, normal blood pressure or well-controlled hypertension with one antihypertensive, minimal proteinuria, and stable on minimum immunosuppression. Calcineurin level should be monitored because fluctuation in level in pregnancy because of the changes in volume of distribution and the clearance of drug. So their dose has to be increased 30%. What are the complications? They can develop hypertension, sometimes permanent loss of graft function, preterm birth, preeclampsia, intrauterine growth restriction. Urinary tract infection. UTI is common in pregnancy. It can be either asymptomatic bacteriuria, it can be a cystitis, or even it can be pyelonephritis. Why? Because smooth muscle relaxation, subsequent ureteral dilatation, the physiological changes in pregnancy facilitate the ascent of bacteria from bladder to kidney. So asymptomatic bacteriuria even increase the risk of pyelonephritis and causing adverse outcomes such as preterm birth or low birth weight baby. So antimicrobial treatment of asymptomatic bacteriuria is needed. Nephrolithiasis. There is significant metabolic changes in pregnancy that can cause stone disease. There are increase in both stone promoting as well as stone inhibiting factors. These stone promoting factors are increase in active vitamin D level that is produced by the placenta and reduced tubular reabsorption of calcium. All these can cause hypocalcemia, normocalcemia with hypercalciuria. And stone inhibiting factors such as increase in uric citrate and magnesium stone inhibitors are increased and increased excretion of acidic glycoprotein. They can inhibit the oxalate formation. What are the challenges? Stones may be difficult to diagnose because hydronephrosis is normal in pregnancy. CT-KUB is contraindicated. Sometimes even extra KUB radio-opaque stones may be obscured by the fetus skeleton, and extracorporeal shockwave lithotripsy is contraindicated in pregnancy because it can damage the fetus. So these are my take-home message. Renal disease during pregnancy carry challenges with respect to distinguishing the physiological changes which are happened during pregnancy from the disease-related manifestation. Increased serum concentration of soluble FMS like tyrosine kinase 1 help in the not only confirm the preeclampsia but also predict the adverse outcome of pregnancy such as intrauterine growth restriction or any IUD. Improve outcome with more intensive hemodialysis in pregnancy. Improve the outcome those who have end-stage kidney disease without residual kidney function. Asymptomatic bacteriuria increase the risk of pyelonephritis, so they need to be treated with antimicrobial treatment. These are my references. So if any female patient come with normal physiological changes of pregnancy, just say them nothing to worry, but don't forget to tell continuous regular follow-up is needed because sometimes they can end up in preeclampsia. Thank you. At this point, I thank to my consultant and current trainer, Dr. A.L.M. Nasas.
Dr. Divakaran, do you regularly look for asymptomatic bacteria in pregnancy, or are there any indications to do that?
Suppose I think if it is asymptomatic bacteria, definitely we have to treat it. But usually everyone not will come with asymptomatic bacteria. So I think if it better if we do, but there's no recommendation like that. But better if do your research.
And I may ask, what is the clinical utility of this soluble endogenous pyrosinase kinase? Is it something that's clinically available?
Not in Sri Lanka, but you can use in other countries because they are at a point like if you have a preeclampsia, sometimes together with a lupus nephritis or other disorder, we have to go ahead with the definitive management. So definitive management is delivery of the baby. At that point, we need to confirm the preeclampsia. So sometimes the clinical changes can mimic. So to confirm that, we have to measure this ratio of this soluble FMS like tyrosine kinase to percentage growth factor. If the ratio is more than 38, that confirm the preeclampsia. At the time, not only confirm, it will tell like the fetus will develop any abnormalities. So we have to go ahead with the urgent delivery to stabilize the patient.
One of the things when we're talking about lupus nephritis, and you were talking about the washout period, which is microfilariates, and what were the other medicines that you said need to be switched to something like azathioprine, but it has been inhibitors?
Generally, MMF have to wash out period of 3 months. If you use the rituximab, that has to be a 1 year, and we can switch to either azathioprine or either any tacrolimus or any.
Yeah, I think the current recommendations with insufficient pregnancy has changed slightly sometimes. So MMF is generally now over 6 weeks, and rituximab also is. And if a patient is on rituximab, it means that they really need rituximab. So to take them off it would be more of a risk from a rheumatological point of view. So that there's a BSR 2023 guideline that was out mid last year. So the recommendations are slightly changed.
Thank you, madam.
Most of the drugs we find inside they are but we can use this information and provides. Also, these drugs don't have a direct antiprotein. But we have high variant of the diet. We even 12 grams per day and trading like 1 So, what is your experience in because they are
I think everyone can.
Is your experience with these drugs? Because these are made for you can't
I sometimes observe everyone can be used, and the using of the AC inhibitor, what they say is don't stop the AC inhibitor when the patient comes to the planning for pregnancy. If you just stop when she confirm the confirmation of the pregnancy, because until that period it will give some real protective effect. So if you stop like 4 or 5 months book, then after 5 months only she got pregnant confirmed. So during that period the proteinuria will get worse. So it's a debatable topic, and they are saying like while stop the pregnancy, while confirm the pregnancy only, like to stop the AC inhibitor at that point rather than stopping before. And as said to ask me like we can continue the epinephrine.
acidity and the strength?
They are comparing like they can cause the congenital abnormalities, but that is very few percentage. I mean, even they say like if the proteinuria is high, there is we can continue, but only is you can't use in the second trimester because they can cause this amniotic. They reduce this amniotic fluid volume and they can show sometimes cause this oligohydramnios and those things. So that is the period in second trimester basically generate to avoid.
Yeah, this with regard to the ECG test, or the nuclear guidelines, they of course not preferable to start they say not to start the ECG test before, but so you will first before that we will not start ECG test for these things. Preferably to stop.
Okay.
And regard to asymptomatic bacteriuria, what they say is there's increased risk of interference, especially starting asymptomatic bacteriuria. So because our families they do treat the patients, even the others are to because there is no value. So there are several studies they have done.
Thank you
very much.
Thank you,
And
sir.
since we are short of time, we have to cut it out. Thank you very much, Dr. Sridharan Thivakaran, for the excellent lecture given.